Good morning, ladies and gentlemen. This is Lieutenant Park. I am a PGY2 resident at NMRTC Camp Pendleton, and today I have the opportunity to tell you about a case, Accessory after the factors, a rare case of acquired Factor VIII inhibitor in an elderly patient on a DOAC. As always, the views expressed in this article are my own and do not necessarily reflect the official policy or position of the Department of the Navy, the Department of Defense, or the United States government. For some helpful background information, acquired factor inhibitors are a rare cause of bleeding, often presenting in elderly patients. The incidence is approximately 1 in 100,000. DOACs, or direct oral anticoagulants, are something that we're quite comfortable with as family medicine physicians and are widespread in their use. Specifically in the DoD system, between 2015 and 2018, approximately 350,000 new prescriptions for DOACs were started. In thinking about this case, it's also helpful to think about the coagulation cascade in the way that Factor Xa medicine, like DOACs, 10A inhibitors, could be presenting similarly to a Factor VIII inhibitor in terms of their symptoms and their initial coagulation workup. My plan for this talk is to take you through the case that initially sparked my interest in this topic. We'll compare that case to previous literature and previous case report. We'll then have a discussion about the implications for future practice as I answer the scholarly questions that first attracted me to this case. I'll then end with some concluding remarks, and we'll transition into our question and answer segment.
A 75-year-old male with atrial fibrillation on a DOAC presented to the emergency department with concern of extreme fatigue and easy bleeding. He had noted frank hematuria at home as well as 2 large bruises on his bilateral forearms. His initial hemoglobin 4.8, and he was transfused 2 units of packed red blood cells.
On admission med reconciliation, it was noted that he had been taking his DOAC at 3 times the prescribed dose. He had had his dose previously decreased due to worsening kidney function, but had continued to take his old prescription in addition to the new lower dose prescription. This abnormality was noted in clinic 1 week prior, and he had been instructed to hold his DOAC. His PTT on admission was noted to be elevated at 142 seconds. This was consistent with 1 week earlier in clinic, despite having held his DOAC for several days. He was admitted to the hospital, but continued to have frank hematuria and bleeding. His PTT failed to downtrend as expected, and an expanded workup was then initiated. Mixing studies were obtained and suggestive of factor inhibition. Factor activity assays were then completed, and the patient was found to have an acquired Factor VIII inhibitor. Treatment was started with steroids, and the patient had normalization of his PTT on 1-month follow-up. He was also given Factor VIII supplementation and continued to hold his DOAC. Moving into discussion, this case prompted my curiosity for several reasons, but the 2 clinical questions that most prompted my interest and made me want to explore the topics further. One, I wanted to know in patients on anticoagulation when it would be appropriate to expand workup for underlying bleeding disorders. I also wanted to know if there was evidence that DOAC use could delay diagnosis of superimposed bleeding disorders in other patients. Comparing this case against previous literature, I found only one similar case. This was a 2014 case of acquired hemophilia, so again another Factor VIII inhibitor, presenting in a patient who required surgery. In comparing and contrasting these cases, they were quite similar in terms of both patient and presentation. In both cases, it was an elderly patient on a DOAC for the purpose of anticoagulation in the setting of atrial fibrillation, and they were presenting in a peritraumatic or perisurgical setting. Both had delayed normalization of their PTT despite holding their DOAC. One would expect their DOAC to have cleared their system in approximately 2 to 3 days due to a half-life of 12 hours. However, as can be seen in the graphic to the right from the study I'm comparing against, the PTT remained elevated in that patient, similar to the table earlier of my own patient. The previous case also noted that this may have caused a delay in diagnosis and a subsequent delay in care in the form of postponement of surgery. Similarly, one could argue that my case shows a delay in diagnosis due to the fact that the DOAC misuse was identified a week earlier in clinic and should have normalized. One difference between the cases is the differences in comorbid conditions. One of the things that was used to justify the delayed clearance in my patient was the fact that my patient had worsening kidney function and had been taking supratherapeutic doses, for which it would be unclear exactly how quickly one could expect normalization of the PTT and bleeding. Similarly, this may have led to a delay in care in the form of the need for transfusion, as the patient did not have normalization of his coagulation studies until a week after admission. Based on this concern for a possible delay in care, I wanted to better understand the coagulopathic workup and those on anticoagulation. The Bethesda assay is the assay of choice for factor activity. As you can see from the graphic to the right, it involves mixing a standard normal plasma 1:1 with buffer as the comparator group against a mix of 1:1 normal plasma with patient plasma in the subsequent measurement of PTT. However, this can be complicated by the presence of multiple factors, and specifically in this case, the question being, was the prolongment of PTT due to TIN-A inhibitor in the form of DOAC, or in the form of an intrinsic Factor VIII inhibitor as was subsequently discovered. In order to appropriately measure factor activity levels in a patient on a DOAC, one must use the Nijmegen assay, which involves using specific factor-deficient plasma in the place of buffer, and use that as the comparator group. However, that can still have some derangements in the setting of DOAC use. The gold standard for patients on a DOAC who are receiving coagulopathic workup would be either the direct measurement of DOAC levels or the immobilization of DOAC through the use of reagents. However, neither of these techniques are readily available. The management of this patient and the treatment of his issue was fairly prototypical. It was focused on avoiding anticoagulants in the form of his DOAC, factor replacement in the form of porcine factor VIII, and immunosuppression. He did receive prednisone. However, in patients who are refractory to prednisone treatment, they can also be treated with other immunosuppressants in the form of cyclophosphamide or rituximab. However, that was not required for this patient in order to get appropriate control of his bleeding. In closing, while DOACs are a popular anticoagulant, they can cause difficulties when detecting superimposed bleeding disorders. While the de novo development of bleeding disorders is rare, the number of patients on DOACs nationally and even just within the DoD system suggests that several similar cases could occur each year. As has been noted, there are limitations to the laboratory workup of a bleeding disorder in those on a DOAC, and better availability of gold standard laboratory testing should be made available. In patients presenting with severe bleeding, symptomatic anemia requiring transfusion, or PTT elevations to several times the upper limit of normal, it is likely that expedited workup, including factor activities, should be reasonable. Thank you for your time.
I look forward to fielding your questions.